So, just adjust that. I'm here to talk to you about a service that replaces what ATAPs did, but what you've heard tonight as well, obviously, is that there's a lot of other services now that could work alongside this one. So I'll just put it in the context of, it's sort of the old toolkit in the middle of a bunch of new services. So currently it's commissioned till 30 June 2018, and it's for people who have access difficulties for traditional mental health support. So Medicare is your first line of support for most people, and on the more extreme side, the local health district. But this program has got limited funding, and it's particularly intended for people who might not access mental health services otherwise. So there's a lot of reasons people might not access services. Originally it was intended for people who live in rural and remote communities. There's providers we don't have remote communities here, but certainly in Brooklyn and Galston and Durrell, we have people providing services as a result. More appropriate for tonight for children and young people. Oftentimes in this region, services are quite expensive and there might be a gap payment. So not having a gap payment when you're a young person is quite a helpful thing. However, this sits alongside Headspace in that regard, because if there's a Headspace site available, it's a somewhat similar cohort of clients. So again, it's using your discretion if there's a service available. People at risk of homelessness, people with, say, depression and comorbid intellectual disability, culturally and linguistically diverse groups, people at non-urgent risk of suicide, the list goes on. But mainly the underlying message is people who might not access a service otherwise, usually because they can't afford the service or because there's some barrier to accessing that service. I won't talk much about that, but it's the general sort of one-to-one psychological interventions are available. The providers are from a range of disciplines, generally psychologists, mental health nurses, social workers, and occupational therapists. So how it works. So there's 3 types of service components. I think I'm too tall. Available. So different to ATAPs, where there was sort of just a 6 one-hour session model. There's an allocation here for assessment to be a bit longer and to take the time and to either confirm a diagnosis if the GP's queried it, or to just put the extra effort into planning things out. There's also at the bottom clinical liaison and coordination time allocations with some referrals, so that gives a chance to talk to the GP, psychiatrists, other providers, family, friends. And of course, there's the actual one-to-one or one-to-two, or however many people are involved, service contacts with the patient. How it's delivered, as David alluded to earlier, is also more flexible. So traditionally, we just had one-to-one face-to-face sessions, similar to Medicare. But now there's alternative options. So if a referral comes through and the provider isn't able to see them for 2 weeks, because that happens a fair bit in northern Sydney, but they're able to make a phone call session right away and do initial risk assessment and start a relationship with that person leading up to a face-to-face appointment, that's an option. So telephone is acceptable. Alternatively, sometimes it's raining and sometimes your younger clients might not want to attend, or your older clients might not want to attend because they'll slip or because it represents a barrier. So there's an option for either telephone or internet versions available then too. So it could be chat or Skype or whatever mediums are available. That's the table picture, but luckily it gets slightly bigger. Effectively, all the referrals for this program go through the Phn Triage. So that's the box there. And then they come through to us generally if that's where they go. And this just shows that there's different modalities that can be used. So the providers get an allocation of hours, and they can use that quite flexibly with the clients. So it could be divided up into 30-minute appointments by telephone if that's easier, if someone's fitting in after school, or if it's someone who might have done 4 face-to-face 1-hour sessions and the treating psychologist wants to call them up for half an hour for the next 4 weeks just to see how they're going, there's some flexibility there. And at the end of that, of course, and at the beginning of it, the GP should get a report initially on how the person's presented and what their presenting issues were, and at conclusion, obviously a conclusion report in summary. Just examples of potential service allocations. They're not indicative, but for say, mild to moderate depression, a person might get an 8-hour allocation, which could get used for, say, an hour and a half of assessment, 6 hours of one-to-one telephone, face-to-face sessions, and then some half-hour of clinical liaison time. Whereas if there was, say, a mild to moderate risk of suicide and more suicidal ideation without a specific plan or intent, nothing that would be referred to the health district, you might have a bigger time allocation. So an hour and a half of assessment in this example, 10 hours of structured intervention, and an hour of liaison time. That's a lot of words. The next two slides are mainly just to reiterate that if you think there's an imminent threat, particularly for a suicide referral, this isn't the appropriate service. They should still go through a mental health telephone line or 000. But if they have protective factors in place, if they don't have a specific plan or they don't have intent, and if you're a bit worried about them but you're comfortable enough that they can wait 2 business days before being contacted, then this is probably a good choice for a service. If they're not suicidal, also don't mind this one, but this is just a K10 distribution. So this doesn't override anything with your clinical judgment. We still defer to that. But if they are 0 to 19, it might be an option that they might use, say, Lifeline in the first instance to do ECBT, and particularly if they're a young person, that could be an option, and some structured telephone sessions. And then if that's not appropriate, they can step up and still come back to this program. Alternatively, if the K10 was, say, 48 and you're quite worried about them, it's probably also not the right program. So they might be more appropriate for paramedic admission, which was Unani Recovery, or they might even be appropriate for mental health drug and alcohol program with the health district. So we sit in the middle, and we're there to be flexible and to try to support people with mild to moderate mental illness. And if in doubt, just call the triage line, and they're happy to walk you through the options. So in conclusion, important changes from ATAPS. The service is now more flexible in terms of how we deliver it. It's comprehensive in its integrated approach, and there's a bigger focus on assessment and case management, care coordination. Another difference is there's an allocated amount, but it's not unlimited sessions without any sort of review. So there's no traditional suicide pathway. If someone has gone and seen the practitioner for, say, 10 or 12 hours, we would expect them to go back and see their GP at some point. So we don't necessarily want to see them 20 or 30 times, just for example, and that never happened in this region. But originally, the Department of Health used to say unlimited sessions was the ideal for that pathway, and we want people to still be seeing their primary care providers. And we're not an acute suicide prevention service, but there are other services. If someone's attempted, CCMB is in the back, and they have an aftercare service. And of course, when in doubt, use the mental health, drug and alcohol services. I think that's everything I had to say.